Good afternoon, everyone. Presenting my paper on juvenile double seronegative myasthenia gravis, decoding diagnostic dilemma. Myasthenia gravis is an autoimmune disease which is usually caused by autoantibodies against acetylcholine receptor and the MuSK antibodies. But there are certain myasthenia gravis patients who do not have both of these antibodies, and they are said to be double seronegative myasthenia gravis. These are probably due to the newer antibodies which contribute to their double seronegativity. But what happens is there is a delay in diagnosis, and that may result in delay in treatment initiation. So the objective of this paper was to describe clinical features, serological profile and response to neurophysiological tests in children who are suffering with double seronegative juvenile myasthenia gravis. This was a cross-sectional retrospective analysis of all the children who presented to us with fluctuating muscle weakness and fatigability which fitted with myasthenia gravis clinical diagnosis. They underwent a laboratory assessment of acetylcholine receptor antibodies and MuSK antibodies. Those who turned out to be negative for both of these antibodies were termed as double seronegative, and they underwent neurophysiological tests in the form of repetitive nerve stimulation and the extended antibody assessment of LRP4, ASK and cortactin antibodies. Who did not have serum antibody dosage performed were taken for exclusive criteria. At 18 months follow-up, we assessed the patient with the help of myasthenia gravis composite scale. The outcomes were termed as adequate response if there is more than 3-point fall in the myasthenia gravis composite scale, and partial response if there is less than 3-point fall, or refractory response when there is no improvement even with corticosteroids. There were, of the total 52 children who had myasthenia gravis symptoms, 8 patients were double seronegative, amounting to 15%. The mean age was 12 years and the female ratio was preponderance. Of the total 8 double seronegative myasthenia gravis, 3 were positive for LRP4, 2 were positive for cortactin antibodies and 3 were inconclusive. All of them had a myasthenia gravis composite score of 3 to 4, showing that they were mainly ocular symptoms, and the treatment was perfectly adequate in LRP4 antibody positive children, whereas immunosuppressants were required in cortactin antibody. Of all the children who were subjected to repetitive nerve stimulation test, 5 children were positive and 3 children were negative, who then turned out to be positive for single fiber electromyography. So why does double seronegative children becomes important? This was a child who was operated for intermittent exotropia, later referred when he developed a diurnal variation of the ptosis after about 6 months following intermittent exotropia surgery. And IcePac was positive of an extended antibody assay, turned out to be positive for LRP4 antibody. So the children who have intermittent XTs or fluctuating diplopia, when they are double seronegative and negative for both RNST, they can be confusing and can be treated by surgery unknowingly. So the discussion is 15% of generalized myasthenia gravis and 50% of patients with double ocular forms are positive for double seronegativity. But the previous studies were done only in adults. So in our study, we studied double seronegativity in children because that is where double seronegativity is more common and they mainly present with ocular symptoms. So we ophthalmologists may be the first contact doctor in most of the double seronegative juvenile myasthenia gravis. So high index of suspicion should be positive from our side. The most common autoantibody found is LRP4 autoantibodies, and this is in concordance with the previous studies too. The prognosis is excellent with LRP4 antibody. Those children who had cortactin antibody, they needed immunosuppressants as an additional therapy, and the single fiber electromyography is more sensitive than repetitive nerve stimulation test in all of these double seronegative children. So conclusion, a successful myasthenia gravis treatment requires an early diagnosis. In case of double seronegativity, this early diagnosis is hindered because of normal antibodies being absent. So we have to use a cocktail tests of clinical, serological and electrophysiological test, put all of these together with a high index of suspicion. When we adhere to the treatment guidelines of myasthenia gravis, despite double seronegativity in children, prognosis remains excellent. These are my references, and remember, suspicion, always suspect the unlikely. Thank you.
In how many cases did you do penicillin test?
Tensilon test was done only in 5 cases because they are children, sir. Usually it's comparatively difficult and a bit of more risky in case of children. So we did a combination of clinical assessment, serological, as well as the neurophysiological assessment in all of these children.
Is acetylcholine presmimetic or presmimetic?
Presmimetics.
Mimetic.
Mimetic.
You see, the acetylcholine is easily destroyed by it doesn't remain in the body. It is destroyed by the cholinesterase.
Yes.
If you got a stuff like anticholinesterase, you preserve the acetylcholine. What are the other forms causes of the ptosis?
Other?
You see, it does cause ptosis.
Yes, sir.
You have a simple ptosis associated with the deformative leads ptosis. Ptosis associated with the syncotic movements of jaw leads syncotic ptosis. Ptosis associated with the varying degrees of extra-ophthalmoplegia. You have got a sympathetic ptosis, which is associated with congenital sympathetic pulses. You have got a periodic ptosis, cyclo-oculomotor syndrome. You have got an intermittent pseudotosis associated with Down's reduction syndrome. If you remember this classification, it's very good. Thank you very much.
Thank you, sir. Thank you, ma'am. Yes.
Did you test for, did you do a CT test for thymoma?
CT test was done in nearly 70% of the children who could afford for it, and most of them were thymoma negative in these cases, ma'am. So none of them had any need for thymectomy in these children, so I did not include it as a part of the line, but 70% of the children underwent CT test for the assessment of thymoma.
And the medication that you gave was, what was the medication given?
Ma'am, when they came to us only with ocular symptoms, the pediatric neurologist initially started with pyridostigmine. But if they were going to them initially with both ocular as well as systemic, then he started a cocktail of pyridostigmine with corticosteroids. In our ocular symptom, children with only predominantly ocular, he assessed for a period of 4 weeks, 1 mg per kg for about 4 QID dosage if he felt still maybe from our side the movements are not resolved or the ptosis is not resolved. In those situations, they added a step up of corticosteroids. Later, based on our inference as to how the child is responding, he did taper the pyridostigmine, but then the tapering of the corticosteroids has taken quite a bit of time in most of these double seronegative cases. It has been continued in a small dosage for up till 1 year to 1.5 years in children. There were those with cortactin positive. One child still did not show improvement with steroids, and azathioprine was started in that child, and he's showing a good treatment with azathioprine, but still he is on azathioprine, and the corticosteroid also is continued in a very small dose in that child till now, which will be tapered over the period of next another 6 to 7 months, ma'am.
Did you use neostigmine substitutes?
Pyridostigmine has been used, sir. Yes, that's the first line of the management.
Any recurrence after stopping the medication?
Till now, none of these children have shown any recurrence, but only 2 children have been completely tapered off the pyridostigmine and corticosteroids till date. The rest of the 6 are still being continued, so the stopping part in these children is taking a bit of extra time as compared to those who were acetylcholine receptor positive children. They have shown a good prognosis as compared to these kids in whom a longer dose is required for the treatment part.
How much is your follow-up till now?
Till now, the statistical analysis was done at 18 months, but right now I have finished 2.5 years of follow-up with most of these children, ma'am.
And what is the common age range in your study? Means most
from around, children? If we take a range, it is about 8 to 16 years of age. The mean has come at around 12 years, madam.
Okay.
Very good.
Thank you.
Thank you, ma'am. Thank you, sir.
Thank you very much.
So, Dr. Merin Nana Raju. Yeah. Please come on the dais and you can start your presentation.
Good afternoon, everybody. Today, the topic of discussion will be on optic nerve sheath fenestration for vision loss in cerebral venous thrombosis and outcome case series. The aim of the study was to evaluate outcomes in cerebral sinus thrombosis associated vision loss, those patients who were treated with optic nerve sheath fenestration. So, cerebral venous thrombosis presents with headaches, focal deficit seizures, encephalopathy, or intracranial hypertension-like syndrome. Vision loss is a dreaded complication which occurs in 13 to 30% of patients. The mechanism for visual impairment is complicated and includes primary venous ischemia and secondary intracranial hypertension, which causes post-papilledema optic nerve dysfunction. Medical treatment for CVT includes anticoagulants, ICP lowering medications, and repeated lumbar puncture, which effectively reduce CVT associated mortality. CSF shunt surgery, mainly the thecoperitoneal shunt, is often performed in CVT patients with persisting and severe vision loss and headache, symptoms of increased intracranial tension despite the best medical treatment. Optic nerve sheath fenestration, which involves cutting slits or windows in optic nerve sheath to allow CSF to escape, is the other surgical procedure for protecting the visual function of patients with IIH. The need for this study is because the mechanism of vision loss is complex in CVT, and it's unclear whether ONSF could help improve visual impairment in CVT. There is limited reports in literature of the effectiveness of ONSF in improving or preserving the baseline visual acuity in CVT patients. Therefore, an evaluation of ONSF efficacy and safety for vision loss in CVT is much required. The methodology in this study was a retrospective case review over the period of January 2023 to December 2024, and patients who had CVT with vision loss and no response to the best medical management, and those who underwent surgery for progressive vision loss due to CVT were included, whereas the patients with CVT without vision loss and those who improved with adequate medical management were excluded. The age group included from 22 to 33. These patients were referred with progressive vision loss was referred from neurology, and detailed ocular evaluation was done, which included visual acuity, color vision, perimetry, B-scan ONST, and the patients underwent these tests post-surgery also. The results include the gender distribution for the study was equally distributed among male and female, and the cause include in 50% of the cases polycythemia vera, and another 25% raised ICT syndrome, and other group anti-RNPSM antibody. The results showed that out of the 4 patients who underwent the surgery, 2 patients showed significant improvement in visual acuity, 1 patient showed improvement in the perimetry fields, and whereas the vision remained status quo for 1. These are the images showing the preoperative and postoperative B-scan, which show the decrease in ONST values, and the fundus photograph, which shows decrease in the grade of papilledema. So the best visual improvement occurred in 1 patient with mainly vision field loss, which was of acute onset, and marginal improvement of status quo vision occurred in the other 3. So coming to discussion, the visual outcome following ONSF in patient with vision loss due to CVT was poor in the small series of patients. The pathophysiology of vision loss in CVT is complex, and it includes both primary venous ischemia and it occurs secondary to intracranial hypertension. So ONSF, by facilitating the drainage of CSF, mainly targets the compression of optic nerve secondary to intracranial hypertension and not the venous ischemia, which is caused by CVT. The postoperative substantial reduction in papilledema severity and ONST supports the theory that visual loss in CVT is multifactorial and not only due to the intracranial hypertension. In the 2 patients who showed minimal or no improvement in visual acuity despite the reduction of papilledema and ONST, the visual loss was chronic. The chronicity of the raised ICP is most likely to have caused an irreversible optic nerve fiber damage, which led to the poor improvement in visual acuity despite the anatomical success of the procedure. Therefore, the patient with CVT should undergo frequent ophthalmological evaluation to detect early vision loss and institution of early treatment when vision loss is detected. In conclusion, the overall visual outcome was poor despite aggressive medical therapy and surgical intervention in patients with visual loss due to CVT. Regular monitoring of the visual function to detect early vision loss will reduce the burden of severe irreversible vision loss in CVT. The limitations in the study included the limited number of patients, as vision loss in CVT is not very common. More prospective studies with larger cohort is required. These are my references. Thank you.
2 things are very important in the optic nerve. One is the blood supply of the optic nerve. According to Surjan Khare, who did a revolution in the optic nerve blood supply. You know, optic nerve is supplied by posterior artery.
Yes, sir.
It's a branch of ophthalmic artery. It arises from the first digit of intercarotid artery. According to Surjan Khare, posterior artery, after supplying the disc, has a segmental distribution, the choroid and the epiphytic choroid. So if there's a deficiency in the blood supply, that doesn't produce changes only in the choroid, but in the epiphytic choroid, characterized by the covenant optic nerve. Filling of the blood in the posterior artery depends upon the difference of the intraocular pressure and the perforation pressure at the optic nerve. Greater the difference, better. So when the intraocular pressure goes down, pressure goes better filling. That gives us the scenario of the optic neuropathy. The second question is the CSF circulation. 70% of the CSF is produced by the arachnoid villi of the choroidal plexus in the lateral ventricle. From the lateral ventricle comes to third ventricle through the foramen of Monro. From the third ventricle comes to the fourth ventricle through the aqueous cilius, and then in the venous sinuses by foramen of Luchka-Meninges. So you have to know the basically. So there's a difference between an MS and the FRCS. Our DNB MS will be very good, but it lacks the basic sinuses. I did FRCS part 1 at the age of 70 or 68 years. I had to read. And when you go, that's why I remember a little bit of this thing, because when I was in the outside, they don't consider our MS and the DNB. They make us specialists. They're not wrong also, they're not right also. So I was made a consultant, and the people objected that Dr. Gohar has got only MS. But the director was better, he made me a shoot consultant, but then I had to do the FRCS, which I did, very difficult. There's a negative marking in the Edinburgh. That's why you see that you have to know the basic science. Your presentation is very good.
Thanks.
Thank you very much.
So, the optic nerve sheath fenestration was done by which route?
Medial conjunctival route, ma'am.
Medial and?
Medial conjunctival peritomy was done. Medial canthotomy approach was done.
Have you just got through the Dr. A.K. Grover's references? He has done a lot of work on this optic nerve. This. You know Dr. Ashok Kumar Grover?
Yes, sir.
What is the, after how many, what is the period of between diagnosis and doing the fenestration? Average time?
Ma'am, ideally as soon as possible, because anyway the patient is already on the maximum medical therapy, and more time we lose, there is more chance
In
of.
your study, when was it done?
Within a week, ma'am. Within a week.
But how will you know whether there is a response with maximum medical therapy? Did you find out within a week? You said after maximum medical therapy, if not responding, then the
Yes.
fenestration was done.
Yes, ma'am. So at the time the patient was referred to us, ma'am, the patient was already on the maximum possible, like acetazolamide 2 gram per day, already on IV mannitol TID.
Since
By the time they presented to us, ma'am.
So, based on this, when did the patient present and when did you take him for the fenestration? What was the time gap? Considering anywhere he might have visited before you. So, what was the time from onset of symptoms or onset of clinical signs to optic nerve sheath
But as she has
presentation?
correctly said, it is a kind of an emergency. It should be done as early as possible.
When did you do in your study? In these 5 subjects, what was the mean time from presenting
Within like
to
a
the
week,
first
week or
doctor?
2 weeks, ma'am, after the patient presented to us.
No, to you, but you are saying
may
he was
have-
already on therapy before that.
he may have
Yeah.
been on therapy since 1 year.
Okay, yes, ma'am.
So you didn't analyze that part, that when was the patient diagnosed and started on medical treatment anywhere?
Less than 6 months, ma'am, not more than 6
So it
months.
was almost 6 months
Almost 6
gap.
months.
And were they getting anything for the venous sinus thrombosis also? You mentioned acetazolamide mannitol. but
They were
anything
on
else?
this anticoagulants, ma'am, already.
Which ones usually? What is given in these cases? Was it started to them or were they only on the ICT lowering agents?
I think these 4 were only on ICP lowering, ma'am, not on
So if you are
anticoagulants.
not treating the cause for 6 months, you cannot expect a response when you
response.
are taking them. Okay. Thank
Thank
you.
you.
Thank you.
Dr. Utami Noor Saibinia, please come to the dais.
Thank you. Good afternoon, everyone and organizing committee. My name is Utami. I'm delighted to present our study on retinal ganglion cell changes due to transsynaptic retrograde degeneration in posterior pathway lesions. Axonal degeneration occurs when nerve fibers lose function after injury. If degeneration progresses towards the cell body, it is called retrograde. In transsynaptic retrograde degeneration, the damage in in the central nervous system can cause atrophy in the neurons across the synapse. Stroke can cause visual field defects like homonymous hemianopia and also structural retinal changes, even with the normal fundus appearance. And occipital lesions can cause retrograde loss of retinal ganglion cell or GCC, which can cause GCC thinning, which can be detected by OCT and sometimes mirroring the visual field defect. Detecting these changes is crucial, and OCT can serve as a tool for this evaluation. Our purpose of this study is to explore the OCT parameters and the potential connection between the retinal GCC and visual field defect in stroke patients. So we included observed prospectively stroke patients with visual field defect, and we analyzed the macular GCC and retinal fiber layer using OCT. We used the term hemifield atrophy to describe the loss of retinal ganglion cells in retinal hemifield corresponding with the homonymous visual field defect. And it is defined as significant GCC thinning in the affected hemifield less than 90% of the unaffected hemifield. I'm sorry, more than 90% of the affected hemifield. We will use only four sectors which did not crossing the midline. And we have 54 patients in this study. And our finding shows that around 63% of stroke patients with visual field defect showing visible hemiatrophy. And this GCC thinning were more significant seen in the patient with longer post-stroke duration. And we also found correlation between GCC thinning sectoral with the visual field defect. Here we present some of the cases of the GCC thinning with corresponding field defect in stroke patients. This one is female, 58 years old, with 3 to 4 months post-stroke. We could see that the lesion is on the left occipital area, and the Humphrey showed right homonymous inferior quadrant ranopia, and the OCT showed GCC thinning correspond with the visual field. Another case, male 59 years old with 1.5 years stroke in the right occipital area. Humphrey showed left homonymous hemianopia, and the OCT showed GCC thinning correspond to the visual field defect. This one also a female, 50 years old with 6 years post-stroke, with the Humphrey showed right hemianopia, and the OCT showed GCC thinning also correspond with the visual field defect. So to summarize, GCC thinning could be found in patients with stroke with visual field defect, and this could be serve as an indicator for TSRD in stroke patient with visual field defect. However, further study is required to understand the evolution of retinal ganglion cell complex during the process of TSRD. Thank you for your time. I'd be happy to take any questions.
What was the time when you performed the OCT? After stroke, how long after the stroke was the OCT performed on these patients?
So the mean time for the examination is 27 months, ma'am. The earliest is 1 month post-stroke, and the latest is 26 years. So we usually have stroke patients came to our clinic to see, because he came for cataract surgery, and if there is if the patient was having a stroke before the history, then the cataract department will send it to us, and then we will check everything. So we use these patients to check the visual field and also the GCC.
Do you expect that in 1 month also you would find the GCC changes? Did you find?
No, but
But you included all of that?
yes, I included. I just want to know because from the references, first time they will show it more than 3 months, like around 5 months.
What was the incidence of diabetes and hypertension in these stroke patients?
Yeah, most of them have, because they were stroke patients, sir, so they have hypertension and diabetes.
What if a patient of stroke also had glaucoma?
Here we exclude the patient with the glaucoma.
How did you exclude? Like, what if the changes were due to glaucoma? How did you exclude that there was no glaucoma, or based on the optic nerve pressure?
Yeah, first we check, and then we also consult to the glaucoma if there is something, if there is something suspicious, but also we check from the IOP and then of the optic nerve also.
The other most important thing is the disc.
Yes, the disc.
Very important disc.
The disc appears normal, ma'am.
You have got the classification of that. Sometimes you have got what is called as the classification as normal disc, with the pallor of the neuroretinal disc with pallor, focal notching, beam pot cupping. The thing is that the disc is important. Sometimes you have got what's called as a glaucoma suspect. Usually, old school of thought, whatever teachers taught us. Usually, glaucoma suspect, there's a tendency for the vessels to dip at the superior disc margins.
Yeah.
Physiological cup is prominent. But if it doesn't merge with the margin of the disc, then it becomes suspect. It's not only the question of intraocular pressure in the fields. There are three things, 3 F's. Fundus, fields, and the facility of aqueous outflow. Obviously, now you have got a fundus photograph, you have got a OCT macula. It's a good presentation.
Thank you, sir.
Thank you.
Thank you, ma'am.
Dr. Jayashree Kanthalu Narayanamurthy. You can start.
Good afternoon to all. My presentation is on neuro-ophthalmic manifestation of tuberous sclerosis, a case series. Neuro-oculocutaneous syndromes are a group of disorders characterized by multi-system involvement. One among is tuberous sclerosis, affecting 1 in 6,000 population. It is autosomal dominant inheritance. While retinal findings are common in tuberous sclerosis complex and important in diagnosis, it has many neuro-ophthalmic manifestations. These manifestations are important to recognize because they can be a sign of life-threatening disease or may have a significant impact on quality of life. In this case series, we encountered 3 cases of tuberous sclerosis with neuro-ophthalmic manifestation. It is a retrospective analysis of 3 patients who presented in the year 2023. Let us start with case description. Case 1, 13-year-old boy came with complaints of defective vision in both eyes since 1 week. Past history of 1 episodes of neonatal seizure was present. Sibling history of surgical excision of subependymal giant cell astrocytoma tumor removal was done. On general examination, patient had adenoma sebaceum, saccharine patch, subungual fibroma, as-leaf macule. Ocular examination, best corrected visual acuity, bisenal optotype, right eye 1/60, left eye 6/9 partial, pupil right eye showed REPD, color vision both eye defective, visual fields right eye not possible, left eye showed depressed fields. Slit lamp examination, iris shows as-leaf macule. Fundus examination, bilateral papilledema, disc edema was noticed. So we ordered neuroimaging. T1 weighted axial and sagittal section showing large expansile lesion in left side of foramen of Monroe with obstructive hydrocephalus, suggestive of subependymal giant cell astrocytoma. So we referred the patient to neurosurgeon and underwent craniotomy and surgical removal of tumor was done. Histopathological examination confirmed the same diagnosis. Case 2, 9-year-old boy came with complaints of defective vision 3.5 months. Surgical history of excision of SEGA was done 3 months back. Sibling history of features of tuberous sclerosis was present. On general examination, patient had adenoma sebaceum. Ocular examination, best corrected visual acuity, right eye 6/24, left eye 4/60. Color vision both eye defective, visual fields both eye unreliable. Fundus examination showed both eye optic atrophy. So we reassured the patient, advised to continue the neurosurgeon treatment, and last follow-up after 6 months, the patient vision has been improved, right eye 6/12 partial, left eye 6/24. Case 3. A 27-year-old boy came with complaints of both a defective vision since 1 week. On examination, adenoma sebaceum over the face since 15 years. On examination, best corrected visual acuity, both eye were 6/18. Color vision, both eye defective. Visual fields, both eye were normal. And fundus examination shows bilateral disc edema with mid-peripheral hemorrhages and cotton wool spots. So we ordered neuroimaging, which showed T1 weighted coronal and sagittal section showed sega in left side of the foramen of Monroe with obstructive hydrocephalus. So patient was referred to neurosurgeon and underwent craniotomy and surgical removal of tumor. So coming to the discussion part, tuberous sclerosis is a complex multi-system disorders with well-described genetic causes. History. In 1880, von Recklinghausen described TSC as Brown-Willi-Brinkel disease. It manifests as benign hematomas of heart, kidney, brain, skin, and eyes. In 1908, Heinrich Vogt described it as Vogt's triad. In 1911, Serlac described Vogt's triad at epiloia, epilepsy, low intelligence, adenoma sebaceum. In 1932, Van der Heever described it as retinal hematomas or phakomatosis. So, ophthalmic manifestations are iris as-leaf macule, iris hematoma, retinal astrocytic hematoma, exudative RD, optic nerve head hematoma, papilledema. Others are craniopalacies, visual field defects, and cortical visual impairment. So the diagnostic criteria for TSC by International TS Consensus Group, the genetic diagnosis is made on the presence of pathogenic mutation to either the TSC1 gene encoding hamartin or TSC2 gene encoding tuberin. So they inhibit the mammalian target of rapamycin pathway, which results in unregulated cell growth in different germ layers causing hematoma. So the clinical diagnosis is made on the presence of major features and minor features. The criteria for the definitive diagnosis are 2 major features or 1 major feature with 2 or more minor features. The possible diagnoses are either the 1 major features or 2 minor features. So in our case series, the clinical diagnosis was made and defective vision was the chief complaints which is rarely reported. The incidence of SEGA is 5 to 14% and tend to occur in first and second decade of life. In all cases, obstructive hydrocephalus was provoked by large SEGA in lateral ventricles which results in increased ICT and papilledema. Although SEGA are slow growth tumors, they are responsible for about 25% of mortalities associated with TSC. So to conclude, vision loss in tuberous sclerosis can occur due to secondary optic neuropathy. Neuroophthalmic manifestations, though not included in diagnostic criteria, have significant impact on visual function and indicate serious underlying neurological disease requiring urgent workup and treatment. So multidisciplinary team approach is crucial element in improving patient outcome. Thank you.
How many cases had this
3 cases.
optic neuropathies?
3 cases we are.
3 cases. These are usually called as phacoma. It's a group,
Yes.
phacomatosis is a group
Yes.
of conditions where there's a tuber formation in CNS other parts. And the group of the conditions which you have in this thing are SLE, your this tuberous sclerosis, ataxia telangiectasia,
Yes, sir.
neurofibromatosis, arteriovenous aneurysms of brain, the spinal cord. The retinal hematomas are one of the commonest manifestations of tuberous sclerosis.
Tuberous sclerosis.
The hematoma, you get other parts. Besides, they have got a raised intracranial pressure
Yes.
and optic neuropathy. It's a very good presentation. Very good presentation. Thank you very much.
Thank you, sir.
It was a very good presentation.
Thank you.
Just want to know that did you get the genetic testing done for any of these patients?
No, madam. Only the clinical diagnosis based on the ophthalmological and radiological findings only we have to make.
Was there any family history?
Yeah, 2 patients, the same family, madam. Sibling history is there. And among the 2 patients, one patient, 1 month post-op, he was expired because of that some surgical related complications, or he had hemiparesis and seizures and expired.
Anybody else in the family other than the?
No, no.
The other condition where you get this choroidal and the retinal hematomas are neurofibromatosis.
Yes, sir.
That you have to keep in mind.
Yes.
And in the neurofibromatosis, you get angioid streaks, you get a glioma of the optic nerve, you get a iris changes in neurofibromatosis.
Least
But yes, yes. Good.
Okay. Thank you very much.
Thank you.
Thank
Thank
you.
you. Thanks.
Dr. Savita Sorvirat, please present.
Good afternoon, everybody. esteemed panel. So I would be discussing about misleading pale disc, a series of Wolfram syndrome and how we studied them. Let me begin with the story of this 9-year-old boy who presented to us with diminution of vision both eyes, 6 months in duration. At presentation, visual acuity was 6'9", 6'12", with a drop in color vision as well. He read only 7 plates, however there was no RAPD. Anterior segment was normal and fundus showed disc pallor both eyes with a dense temporal pallor. He came to us with these VEP reports which he carried as was advised elsewhere, which showed that both eyes had prolonged P100. Now seeing this, what should be a diagnosis in a 9-year-old boy, both eyes diffuse pallor, prolonged P100? So is it juvenile glaucoma or some hereditary optic atrophy, autosomal dominant or LHON, or a past episode of atypical optic neuritis has happened and gone? Is it a mild CVI or some IXOL causing compressive optic neuropathy? A pause, and then we retook a history which gave us a clue that he had insulin-dependent diabetes mellitus, and on probing further, mild hearing loss. Is it DID mode now? With this, we also advised MRI, atrophic optic nerves were seen, no IXOL, no enhancement of optic nerves. Then a history was taken which was negative again for family history, pedigree was done, and a genetic testing was advised. We were fortunate enough that the patient could afford, so to find that presence of homozygous mutation in WFS1 gene, which now confirmed that it was DID mode. So Wolfram syndrome is a rare autosomal recessive genetic disorder with juvenile onset diabetes mellitus, insipidus, optic nerve atrophy, hearing loss, and neurodegeneration. First reported in 1938 by Wolfram and Wagner, where he found 4 of 8 siblings with juvenile diabetes mellitus and optic nerve atrophy. So it's an autosomal recessive entity with 2 prominent causative genes, WFS1 and WFS2, with early onset diabetes and progressive optic atrophy usually presenting in the first decade, cranial diabetes insipidus with sensory neural deafness in the second decade, renal tract abnormalities in the third decade, and multiple neurological abnormalities such as myoclonus, psychiatric illness in the fourth decade, causing prolonged morbidity. So what does literature say? Where is our role here? Yes, systemic associations have been elaborated more than ocular, but optic atrophy still forms a diagnostic criteria. However, subtle vision loss with mild disc pallor, as in our case, could present with or without ocular associations can be the presenting sign. So a detailed systemic history and workup is necessary for early diagnosis and prompt management. This brings us to our study which we did during the period of 2021 to 2024 as in retrospective analysis with a minimum follow-up of 6 months. All children of more than 5 years were analyzed who had the diagnosis of DID mode on their files. A detailed history and symptoms of systemic associations were noted down. The ocular evaluation was noted down. In anterior segment examination, if there was any dry eye, LSED, cataracts, nystagmus, motility disorders, raised IOP or pigmentary retinopathy was noted. And in follow-up, all of these had undergone a Fields, OCT, RNFL, and MRI brain and orbit with a genetic evaluation. Adequate ocular management was done for them, and low vision services was provided. So we found there were 6 males ranging between 7 to 35 years with mean age of diagnosis 18 years. Our youngest child was 7 years, and our oldest patient was a 31-year-old female who developed gestational diabetes and was then found to have DID mode and diabetes. So diabetes mellitus, as noted in literature, was seen in 100%, and least was genitourinary abnormality in 22% of our patients. Optic disc pallor was seen in all of them, where 56% had temporal, 44 had diffuse. But we also had 10 eyes who had 56 cataracts, again, 5 of them belonging to 2 families, 3 siblings, 1 family, 2 siblings, 1 family. 6 eyes had overlapping glaucomatous cupping also. OCT was done which showed retinal nerve fiber analysis thinning in all 18 eyes. The inheritance was autosomal recessive in a majority. Whole exome sequencing was done. 5 patients were positive for the WFS1 gene. 1 patient was positive for WFS2 gene. 1 adult had separate genes. The adult who was presented at 35 years had an OPI gene for diabetes and WFS1 gene for DID mode. So what does the literature say? Most of the studies discuss as systemic neurologic associations of DID mode. We did study the ocular associations. Optic atrophy and diabetes remains the presenting feature, diagnostic feature presenting in first decade, though in first decade we saw that our series had earlier age of presentation. Hearing loss and genitourinary symptoms also remain common, which was seen in few patients. Genetics testing with genotypic phenotype correlation is a prognostic indicator. WFS gene was positive in 56 patients, but correlation was not done. OCT also showed indicator indicating poor visual prognosis. None except one had neurological implications during follow-up, that was cerebellar ataxia. Ocular associations like cataracts and glaucoma coexist. So it is a phenotypic heterogeneity entity with different clinical manifestations, located on chromosome 4p and encodes protein wolframin, which shows that accumulation of misfolded proteins, and optic atrophy and diabetes thus remain consistent features. Even if children do not present with diabetic mellitus but have optic atrophy, they should be evaluated for Wolfram, as diabetes mellitus can present later. Effective follow-up should include a multidisciplinary approach. Thank you.
It's basically a neurodegenerative disorder which is characterized by the progressive visual loss and
Diabetes.
the hearing impairment. How many cases did you do audiometry?
We did in 3 cases, sir.
So
Audiometry
what was
done.
the pattern? There was a hearing loss?
Yes, there was hearing loss. We did provide hearing aid to 2 of them also.
So basically this is a progressive hearing loss and progressive vision feed that causes this.
How much was the follow-up period? You said progressive optic atrophy. So,
Ma'am, this was a retrospective study, so all those who had 6 months in our database, those we had pulled out.
so was there in the 6 months, was there any progression or it
No.
was just
No, they already had optic atrophy. Some of them were misdiagnosed as glaucoma, and some of them had cataracts.
was the genetic testing done in all?
5 out of 9 underwent genetic testing, ma'am.
In case they first present with optic atrophy without any diabetes, are there any other suspicious signs that you would like to work them up for Wolfram syndrome? Or would it be by exclusion that none of
It
the
is by
others are
exclusion, but
present?
now with literature, this is not very common. So with the literature, knowing the other ocular symptoms should also be looked for. Workup wise, only if you go back to history and find those 3 major criteria, then a genetic workup supports it.
Thank you.
Thank you.
Dr. Anamika Chaudhary.
Good afternoon, everyone present here. Myself, Dr. Anamika Chaudhary. I am here to present on ocular manifestations and visual field patterns in traumatic injury and stroke patients. Traumatic brain injury and stroke are major causes of death and disability around the world. Large portion of the central nervous system is dedicated to vision, and therefore, strokes and TBI have a high likelihood of involving vision in some way or the other. Vascular occlusion along the efferent or the efferent visual pathways can produce myriad effects, including transient monocular vision loss, visual field deficits, and ocular dysmotilities as well. So, in this present research, we analyzed and compared the ocular manifestations and VF patterns in cases of TBI and stroke patients. The aim of my study is to study the ocular manifestations and visual field patterns in traumatic brain injury and stroke patients attending Tertiary Care Center of Jharkhand. It's a retrospective cross-sectional study which included 118 patients with TBI and stroke. The patients with brain injury due to trauma and stroke admitted at our hospitals were included in the study, and the patients with very low general conditions aged less than 18 years and other corneal morbidities were excluded. Patients underwent comprehensive ocular examination, systemic examination, CT scan, and fundus examination also. Standard automated perimetry with central 24-2 threshold test was done. Analysis of demographics, clinical features, and VF results were conducted as well. So the results, we saw that 33.89% patients had been diagnosed with TBI and 66.1% with stroke. The etiology of the TBI showed that traumatic road traffic accident was the major cause in traumatic brain injury patients, followed by self-fall and others. The types of TBI range from subdural hematoma to subarachnoid hemorrhage, extradural hemorrhage, intracranial hemorrhage, diffuse axonal injury, and intraventricular hemorrhage as well. The demographics were compared, and we saw that patients in the stroke were of a higher age group in comparison to that of traumatic brain injury patients. Both hypertension and diabetes were more fondly associated with stroke in comparison to traumatic brain injury patients. The clinical features were compared and seen. Here are some photographs which we have taken during the process. The fundus abnormalities were detected, which were classified into glaucoma suspect, diabetic retinopathy, drusense, vitreous hemorrhage, and optic disc pallor. Coming to the VF defects, we saw that homonymous hemianopia was found to be more commonly associated with stroke, that was in 31.8% cases, in comparison to 14.4% cases of traumatic brain injury. Homonymous quadrianopia was also seen in 12% cases of stroke and 11% of that of TBI. Scattered defect was more common in traumatic brain injury patient, which was 56.5%. Here are some visual field photographs. So coming to the discussion part, the ocular manifestations of TBI and stroke in our cohort are in line with the previous reports of various structural and functional abnormalities. With respect to the present VF defect patterns in TBI, the scattered pattern was the most common, which is inconsistent with the previous study. Visual dysfunction is frequently overlooked and or underestimated in TBI and stroke cases, as the primary focus is often on diagnosing and managing life-threatening systemic conditions. However, visual deficits can significantly impact patients' daily life and negatively affect their rehabilitation and quality of life as well. Therefore, it is crucial to accurately evaluate and rehabilitate visual functions in addition to addressing the physical losses which these patients face. So we concluded that numerous eye-related symptoms are observed, with a significant number of patients experiencing visual field defects and demonstrating unreliable VF test results. Our research highlights the importance of carefully assessing and rehabilitating visual functions in both traumatic brain injury and stroke patients. Beyond addressing systemic health issues, prioritizing visual well-being should also be a central focus in their overall care. Here are some of my references. Thank you.
What was the incidence of squint, diplopia, and ophthalmoplegia and papilledema?
So papilledema was more common in traumatic brain injury patients, and squint was also more common in traumatic brain injury patient because of the nerve entrapments due to fracture of the orbital floor and other.
What was the pattern of the field defects? Was it altitudinal?
Yes, sir. We saw quadrinopia in some cases of traumatic brain injury.
What's the one sign that you would look for? What's the first thing that you would want to look for in these kind of patients?
Ma'am, usually these patients are referred to us from the neuro surgery departments or the medicine departments. So mostly they are sent for fundus examinations. So the first thing which we do is first anterior segment examination and then the fundus examination. So then according to the fundus examination, we suggest the various other tests.
Probably ma'am is telling about the coma score, I think.
What about the pupil?
Yes, ma'am. Pupil also, anterior segment examination.
Pupillary reaction is?
Yes, ma'am. That was checked. That was checked.
Related to afferent pupillary defect.
Yes, sir. Yes, sir. That was checked and compared.
Thank you.
Very good person.
Dr. Anagha Anand.
Good afternoon, everyone. I'm myself, Dr. Anagha Anand. I'm here to present an interesting case on cracking the calcium code, optic neuropathy's intricate link to Fah's disease. There is no financial disclosure in my presentation. First, a brief introduction. Fah's disease is a rare, progressive neurodegenerative disorder characterized by abnormal calcium deficits in areas of brain that control movement, including the basal ganglia and cerebral cortex. It manifests with diverse neurological, psychiatric, and cognitive symptoms and can be classified as primary, which is mostly familial, and secondary, which is often linked with metabolic or endocrine disorders. Here we present a case of optic neuropathy secondary to hypocalcemia in a patient with Fah's syndrome. This case highlights the complex interplay between Fah's syndrome and calcium homeostasis leading to optic nerve dysfunction. So coming to the case report, a 42-year-old male patient came to our hospital with 1-year history of dull headache and painless progressive vision loss in left eye. He reported having squint since childhood with suboptimal vision in his right eye, and his past medical history revealed a thyroidectomy which was performed 20 years ago. His family members had also noticed behavioral changes including forgetfulness, irritability, and confusion. So on examination, his vision in right eye was counting fingers close to face, and in left eye was 660 improving to 624. And the pupillary reaction was sluggish in both eyes. And on anterior segment evaluation, mild proptosis, lid retraction and lid lag was seen in both eyes. Also a 70 prism diopter exotropia was seen in right eye. And there was also nuclear sclerosis of grade 2 in both eyes. And on fundus examination, there was temporal pallor in both eyes. And on systemic examination, his vital signs were normal. Neurological evaluation revealed no focal deficits except mild confusion. There was Trotsky sign positive, Chostic sign positive, suggesting of hypocalcemia, and hence we did the serum calcium levels, and it was found to be low. And these are the lab reports. His parathormone level, serum calcium and vitamin D level were low, and serum phosphorus was high, and his TSH level was normal. Then we did the imaging. Her CT brain and orbit showed symmetrical calcification in bilateral cerebral white matter, thalami, basal ganglia and dentate nucleus, suggestive of Faher's disease. Also mild thyroid-related orbitopathy with normal extraocular muscle thickness and orbital apex was found. MRI brain also showed similar pattern of calcification suggestive of Faher's disease. This is the axial and plane coronal CT image, which shows the coarse calcification involving bilateral capsuloganglionic region, bilateral basal ganglia, and subcortical location of bilateral frontoparietal lobes. So the working diagnosis for this patient involves optic neuropathy in both eyes secondary to hypocalcemia, and this patient was referred to neurology and endocrinology and was started on oral calcium and calcitriol supplementation. Faher's disease is a very rare neurological disease characterized by abnormal calcified deposits in the basal ganglia and other parts of the brain. So when we see this pattern of brain calcification on imaging, we have to exclude neoplastic, infectious, congenital, endocrine, metabolic and other idiopathic causes. So the diagnosis of Faher's disease relies mainly on the combination of clinical symptoms, neuroimaging and the exclusion of other causes of intracranial calcification. In our case, the patient developed hypoparathyroidism following a thyroidectomy which was performed 20 years back, which resulted in the development of Faher's syndrome. And the disruptions in the calcium metabolism and hormonal imbalances are suspected to have played a critical role. Calcium dysregulation, whether due to parathyroid dysfunction or altered vitamin D metabolism, has been implicated in abnormal brain calcification and optic neuropathy. Low serum calcium levels may contribute to both neuronal damage and optic nerve dysfunction. So in nutshell, this case underscores the importance of long-term calcium monitoring in post-thyroidectomy patients, and we recommend regular biochemical assessment and neuroimaging when clinically indicated to enable early detection and management of complications like Faher's syndrome. These are my references. Thank you.
It's basically idiopathic familial basal ganglia calcification.
Yes, sir. Mostly if it is primary, it comes as familial and it has mainly...
Idiopathic familial basal ganglia calcification.
How many cases, such cases reported so far in literature?
Actually, in literature is given incidence is 1 in 10 lakh, and very few case reports are only there in the published till now, ma'am. So it's very
Following
rare.
Thyroidectomy.
Yes,
Any
yeah.
case published before?
Yes, ma'am. Yes, ma'am. Post-thyroidectomy Faher's syndrome is reported, but it is mostly like seizures, like that kind of presentation. But having an optic neuropathy kind of finding is, I didn't find much in the literature, ma'am.
What was the indication of thyroidectomy in this patient?
He had Graves' disease, and so we didn't have any reports or anything, but based on the history, it was suggestive of Graves' disease.
No condition which could have contributed to the
No,
optic
no,
neuropathy,
no,
yeah.
ma'am.
Thank you.
Thank you.
Very good.
Do we have Dr. Uttara Rabidas here? Dr. Rakhi Sen? Dr. Vibha Singh? Do we have Dr. Vibha Singh here? Dr. Anvita Kachap?
Good afternoon, everyone. My free paper is on clinical characteristics and treatment outcomes of optic neuropathy associated with sarcoidosis. Sarcoidosis forms a spectrum of autoinflammatory disorders of unknown etiology characterized by development of immune activation leading to immunologic cascade that results in an inflammatory infiltration of tissues with granuloma formation and later fibrosis. Ophthalmic complications arise in 10 to 50% of the patients. The ophthalmic complications included in my studies are listed below. The aim of my study is to study the clinical characteristics and treatment outcomes in patients of optic neuropathy related to sarcoidosis. Materials and methods. The study was conducted on 11 patients with visual disorders assessed in our department. The investigation protocol. Initial investigation, a series of blood investigations and imaging studies were primarily done to exclude demyelinating systemic autoimmune and infectious or metabolic causes. Granulomatous cause consideration. Granulomatous optic neuropathy was considered when other causes were ruled out. Additional investigations were conducted for patients showing systemic features of sarcoidosis. Diagnostic criteria for sarcoidosis. Histologic proof confirmed granulomatous disorders requiring treatment. Clinical evidence, typical radiological features, hypercalcemia, raised serum ACE levels, or characteristic gallium scintigraphy or PET findings. Exclusion criteria, 17 cases were excluded as they did not fulfill the diagnostic criteria for diagnosis. Ethical considerations, ethical approval was obtained, patients provided informed consent for inclusion. The results, 11 patients were included in my study. The mean age was 42.5 years. Predominantly the female gender was involved. Clinical features, systemic sarcoidosis diagnosis, concurrently diagnosed in 6 patients, previously diagnosed in 5 patients. Systemic involvement, respiratory system involvement was predominant in 8 patients, involvement of orbit and lacrimal glands in 3 patients. Histologic diagnosis confirmed in 9 patients through respiratory tissue biopsy and orbital biopsy. Clinical characteristics of optic neuropathy. Optic neuritis syndrome. 9 patients presented with subacute optic neuropathy evolving over days. Unilateral cases were seen in 6 patients and bilateral cases in 3 patients. Progressive neuropathy. 2 patients experienced slow progressive unilateral optic neuropathy. Symptoms and visual field effects. Pain was reported by 3 patients. Visual field defects included central scotoma in 7 cases and hemianopic defects in 2 cases. Imaging results, the MRI findings showed enhancement of optic nerve and sheaths in 8 patients. 2 cases showed optic perineuritis with predominant sheath involvement. Normal imaging was seen in 3 patients. Treatment, corticosteroid therapy. All 11 patients were treated with oral corticosteroids. 4 patients required IV methylprednisolone before transitioning to oral corticosteroids. Immunosuppressive therapy, 3 patients were given azathioprine and methotrexate due to relapse or incomplete response to corticosteroids. Follow-up, median improvement in visual acuity was plus 0.5. Subacute group showed significant improvement, and progressive group showed no improvement in visual acuity, but resolution of inflammation was seen. Relapse, 3 patients showed relapse. Unique observation in my study, in perineuritis patient, thickened optic nerve sheath was the predominant finding. Both improved with corticosteroid therapy. Discussions. The key findings of this study are clinical presentation often resembled optic neuritis, though it was less painful and sometimes more slowly progressive. Concurrent intraocular inflammation was uncommon, and 64% of the patient had no ocular involvement historically. Most patients improved significantly with corticosteroid treatment even after delayed intervention. However, relapse occurred in 25% of the cases, often requiring immunosuppressant therapy. In severe cases, a subset had progressive disease with widespread neurological improvement, poor visual outcome, and required higher dose of steroid, immunosuppressants, or biological agent. Meningeal inflammation was observed in these cases and in some with subacute course. Mechanism of optic neuropathy. These include optic nerve inflammation, compression by inflammatory masses, ischemic complications, granulomas, or meningeal inflammation. The condition is rare in sarcoidosis, previously reported in 5% of ocular sarcoidosis cases and less frequently in systemic sarcoidosis. Management: high-dose corticosteroids, oral or IV, followed by slow tapering are recommended. Relapses should be treated promptly using immunosuppressive therapy, and cases of neurosarcoidosis require prolonged higher dose of treatment and potentially biological agents for refractory disease. These are my references. Thank you.
When you have sarcoidosis, you have anterior segment manifestations and post. How many cases had a Candlewax appearance?
Sir, around we had 11 patients and almost 5 patients had Candlewax.
What was the incidence of the granuloma of the disc, the retinal granuloma?
Sir, that incidence was low.
How many did you evaluate for bilateral granulomatous pan uveitis? Sarcoidosis is one of the important causes of a granulomatous pan uveitis, and the other deficient diagnosis of granulomatous uveitis are Vukatkayangi, HIV, sarcoidosis, Behçet's, tuberculosis, syphilis, Epstein-Barr virus. Acute uveitis is about 40% in these cases, and the chronic uveitis is 60%. Besides, you have to look for focal perivascularitis and venous occlusion. And is this right? Other thing is that there is a condition which is called as Tulaza-Hunt syndrome. You know Tulaza-Hunt syndrome? Have you seen? Tulaza-Hunt syndrome is a condition where there is basically an autoimmune and an immunological reaction of the substances passing through the cavernous sinuses and the superior orbital fissure. Patient comes with periorbital pain, hemicrania, diplopia. This condition has to be differentiated from the sarcoidosis. What was the incidence of cavernous test? It was positive in sarcoidosis. Did you do it? It has to be done.
Yes,
How many cases of sarcoidosis has hilar lymph node neuropathy?
so respiratory involvement is very common in sarcoidosis.
Yes.
In our cases, we had out of 11
Usually
patients, 9.
whenever I have written an article on sarcoidosis, you have to group it as anterior segment and posterior segment. Anterior segment, you have got sarcoid plex-like chalasia, lacrimal gland involvement, follicular conjunctivitis, follicular conjunctivitis, sicular nodule, heterochromia, uveitis, posterior segment, periretinal nodule, choroid involvement, Candlewax exudate, focal perivascularitis, venous occlusion, glomerulonephritis.
So what would be your take-home message from this? What is the new thing that we learned from this?
Ma'am, the new thing, actually it's not a new thing, but the corticosteroid therapy, if given, it always helps in improvement of the symptoms, and it if given promptly and given in the right manner, it helps in having a good visual prognosis.
Take always the consultation of a pulmonologist.
Yes, sir.
So if there's a diagnosis of sarcoidosis, would you look for ocular signs and symptoms, or would you look for sarcoidosis on the basis of the ocular signs and symptoms? Which one would you?
Ma'am, first one, I guess, because first the patient will have respiratory and other manifestations. After that, he'll have ocular manifestations.
Not necessarily.
Thank you very much.
Yeah.
Okay. Thank you.
Thank you.
Dr. Himadri Chaudhary.
Good afternoon. My paper is Genie in a Bottle, Reversible Nutritional Optic Neuropathy in Northeast India. I do not have any financial interest in this presentation. Among the various colors of Northeast, the Mar, Mizo and Naga are the ones that hail from in and around Assam. I hail from Kachar, so I get a lot of these patients. The background of this study is India has the highest market of smokeless tobacco, and incidentally, Mizoram has the highest prevalence of tobacco consumption. What is not known is liquid tobacco as an entity and its ophthalmic sequelae. The purpose of our study is to report reversible toxic optic neuropathy in 43 young and healthy patients belonging to the indigenous tribal communities of Northeast India. All of them presented with diminution of vision in both eyes. They gave history of intake of liquid tobacco. It is a retrospective case series where detailed medical and dietary history was taken. Clinical evaluation involved color vision, visual fields, and OCT studies. Demography profile, duration and frequency of liquid tobacco use was also taken. So what is this liquid tobacco? I have seen patients sipping this brown colored liquid from a bottle. I was quite intrigued by that. The local name is Tuibur or Hidakfu. It is a form of tobacco water mainly popular in the northeast states of India. It is a widespread social and cultural acceptance. It is as common as tea or coffee, and they have a misconception that water purifies the tobacco. So on investigating further, I visited a Mar village where I saw the production of this tuibur. Here the tobacco are dried and then they are set to fire in this earthen pots, and the earthen pots are connected to glass bottles. With the help of a hand pump, the smoke of the tobacco is percolated or infused into the water until the time the fluid is totally supersaturated with the smoke, and then a cloth filtration is done, and this is the end product. So what is the mechanism of toxicity? Stripping volarimetry of tuibur has shown that there is presence of heavy metals, myosmine, carbon monoxide, and cyanide. All these cause mitochondrial DNA damage. The respiration in the mitochondria is reduced ATP, increased oxidant stress, and all these causes demyelination. The patients were started on vitamin B complex with methylcobalamin. They were advised to discontinue tobacco use. Out of the 43 patients, 83% of the patients were female, 61% were Mar, another 30% belonged to the Naga, Kuki and Mizo, mean age being 29 years, and duration of tuibur intake was mean 7 years. So these are some of the patient, normal looking fundus, normal OCT RNFL, but typically in the perimetry you can see central scotoma at presentation, and after 1 month of treatment you can see reduction of central scotoma. Another patient here presenting with temporal pallor, OCT showing temporal RNFL thinning, and you can see the perimetry, central scotoma, deep central scotoma, but after 3 months of treatment, remarkable improvement in the field, and also the vision is improved. Another case showing again central scotoma. So the logMAR vision at presentation and after 3 months was statistically significant. Vitamin B complex supplementation is successful in treating, and how so? Because of conversion of free cyanide to cyanocobalamin. So all 43 patients had a statistically significant improvement in vision and also the visual field indices after treatment. As you can see here in the parameters of perimetry, visual field index and the pattern standard deviation at presentation and after 3 months of treatment are statistically significant. So tuibur has been reported in literature, but it has been linked to stomach cancer, and there has been some local publications of tuibur, but to the best of our knowledge, this is the first ever study linking liquid tobacco to toxic nutritional optic neuropathy. We conclude that nutritional toxic optic neuropathy can be caused by a multitude of agents. However, the mainstay of treatment is replacing deficient nutrients, eliminating the offending toxin, and it is important to consider contributory social, cultural, and dietary practices. Thank you very much for your kind attention.
So it's a condition of a toxic amblyopia, just like
Kind of.
methyl alcohol, illicit alcohol, done usually in the illiterate forest, they drink illicit alcohol. It's toxic amblyopia.
But the difference here, sir, is...
Was it reversible?
Yes, sir. That is the catch here, that in toxic amblyopia, usually the vision doesn't improve. But here, when we can detect it at a particular time, then and they are stopping that liquid tobacco intake, then the field is also improving.
How are you sure that they will stop?
No, we are not sure. Of course, we are not sure. So the field is also improving.
It's a kind of addiction.
Definitely.
So it's very difficult.
Definitely.
But of course, and then what happens is that there will be withdrawal symptoms. It's very difficult. Basically, do a little bit of pediatric ophthalmology. You've got the children during the period of COVID, when they just do these mobile games and all that stuff.
Yes.
I see the children after COVID brought to the pediatrician because they get eye ache, headache, irritability, change in behavior, migraine, sleeping the phones, then later on they get also delayed milestones, autism, squint, diplopia. And the parents think that they have got a pediatric problem, and only it's an intelligent pediatrician who sends to the patient to a pediatric ophthalmologist that he detects that I got a twin during the period of COVID, 6 years. One was a gentle twin, he was not playing games. Other was a twin. He had a squint of about 25 degrees. And when I assessed minus 2 cylinder 20 degrees, he put it after 1 month, it disappeared. So it's very important that the parents should not give this mobiles and then they play it. Encourage the children to play outside games. Same thing is here. It's a question of addiction. So now we called it as a mobile laptop syndrome. The same thing is here. It's addiction. Well, if it's good, if it's reversible, it's good.
It's very interesting and very well
Very
presented.
interesting. Very interesting.
Thank you.
Yes, thank you.
Dr. Navneet Chabra.
Good afternoon, everyone. I'm Dr. Navneet Chabra from Shankar Netralaya, and today I'll be presenting on Beyond the Obvious, Subtle Clinical Signs and MRI in Diagnosing Pituitary Adenoma. Pituitary adenoma are common intracranial cellular tumors which presents with the symptoms of either hormonal changes or visual dysfunction. In our case series, we present 7 patients who had subtle clinical ophthalmic and systemic signs, but with suspicious disc. On evaluation of MRI, we found them to be having incidentalomas or pituitary adenomas. It was a retrospective observational study conducted by reviewing the medical records of patients who presented with suspicious disc or referred to the Neuro Ophthalmology clinic of a tertiary care eye center. Detailed history, clinical examination along with their visual field, OCT RNFL and MRI findings were noted. Our first case is a 47-year-old male who presented with diminution of vision in left eye since last 3 months. The patient also had a past history of road traffic accident 10 years back, and on examination we found him to be having a 6/18 visual acuity with mild temporal pallor. But his visual fields were surprisingly showing advanced field defect in the left eye and temporal hemianopia in the right eye. Our second patient, a 34-year-old male with history of trauma to left eye with a rubber ball, showed a visual acuity of 6/18 in the left eye with temporal pallor. But his visual fields were normal. As there was a clinical and diagnostic mismatch between the visual fields and the history of the patient, we went ahead and ordered an MRI. And the MRI showed us pituitary macroadenoma. So in all patients of ocular trauma, they may not be a traumatic optic neuropathy. If the disc and visual field findings are not correlating, an MRI can help us in clinching the diagnosis. Our third case was a 47-year-old female who presented with diminution of vision in left eye since last 2 years, associated with headache, nausea and vomiting, but no tinnitus. She had a hand movement visual acuity with temporal pallor. Her OCT RNFL in the left eye showed temporal thinning, but the visual field showed right eye temporal hemifield defect. To find out the cause of raised ICT, an MRI was ordered which revealed pituitary macroadenoma. So in patients with raised ICT and reduced vision field defect, MRI is advisable. Our fourth case was a 19-year-old male, a known case of juvenile open-angle glaucoma on glaucoma medication since last 1 year. But he had reduced vision in one eye severely to counting finger close to face, while the other eye had a visual acuity of 6/18. His optic disc were showing both eye severe disc pallor, and the left eye visual field showed a temporal field defect respecting the vertical midline. As these findings were not suggestive of glaucoma, an MRI was advised, which again showed us pituitary macroadenoma. So in glaucoma patients with pale disc hemifield defects, MRI is recommended. Our fifth patient, a 67-year-old female with primary open-angle glaucoma on glaucoma medication since last 3 years with a cup disc ratio of 0.5, presented with sudden onset diplopia since last 4 days associated with an esotropia and abduction limitation. Her OCT RNFL and visual fields were normal, but she had sudden onset diplopia. To find out its cause, an MRI was done, revealing pituitary macroadenoma. So in glaucoma patients with sudden onset diplopia strabismus, MRI is recommended. Our sixth patient, a 48-year-old male with diminution of vision in right eye more than the left. He also had a past history of completing an antitubercular treatment and presented with a visual acuity of 3 meter in the right eye and bilateral temporal pallor. His OCT RNFL though was normal, but the visual field showed temporal field defect in the right eye. Since the findings were not suggestive of ethambutol toxicity, we ordered an MRI showing pituitary macroadenoma. So in ethambutol toxicity patients with asymmetric vision and field defect, MRI is warranted. Our last case was a 68-year-old male with diminution of vision in right eye since 8 months associated with a history of chronic tobacco addiction. He had a chalky white disc with 3 meter vision in the right eye with a severe thinning in the right eye OCT RNFL, but the visual field and OCT in the left eye were normal. As the findings were not matching with toxic optic neuropathy, an MRI was advised suggesting pituitary macroadenoma. So in toxic optic neuropathy patients with reduced vision, RNFL thinning and no central field defect, neuroimaging is an advisable investigation. Pituitary adenoma patients can present with optic nerve dysfunction due to a compressive optic neuropathy. They can also present with systemic symptoms due to altered hormonal levels or raised ICT. Visual fields and OCT along with history and investigations help us in early detection of these lesions. OCT changes may precede the field defect, and RNFL loss does correlate with the postoperative visual recovery of patients. Our patients had history of trauma, glaucoma, antitubercular treatment and addiction, but their marked temporal disc pallor and field defects along with neurological localizing sign prompted us for neuroimaging. So MRI in patients with suspicious discs and clinical diagnostic mismatch can help us in incidental diagnosis of pituitary adenoma. These are my references. Thank you.
Did you get anything other than the pituitary adenoma on MRI?
Yes, ma'am. 2 patients did have meningioma. Since the series was on adenoma, we did not include them, but we did find meningioma also in 2 patients.
So basically, imaging is important in all, optic nerve diseases.
Lesions. Yes, ma'am.
How many had enlargement of the blind spot?
So enlargement of the blind spot was seen in all of them because they had a temporal field defect. In whichever patients we could do a field testing, those who had reduced visual acuity of end movements, visual testing could not be done.
How many had superior temporal compression?
So 1 patient had a superior temporal compression.
Can you tell us why diplopia happens in a case of pituitary adenoma?
Ma'am, diplopia can happen in the patients of pituitary adenoma because of the compressive nature of the tumor compressing the 6th cranial nerve.
Is there any other mechanism, and was there any abduction deficit in these patients?
Yes, ma'am. In 1 patient, we had abduction deficit who presented with sudden onset diplopia. There is a clinical entity in which the patient may have diplopia, but there is no reduction in the extraocular motility of the patient. So we can have that kind of clinical condition.
What is that called? Is there any name to it?
Yes, ma'am. It is a named condition, but I do not know the specific name.
Very good.
Thank you, ma'am.
Sometimes in some atypical case of chronic glaucoma with the unusual field defects, it's very important to do to exclude pituitary adenoma. Very good.
Thank you, sir. Thank you, ma'am.
I think I should say that I have not seen such excellent presentations of beyond. I should congratulate all the speakers for their excellent presentation.
Yeah, very good presentations.
Very good
Very
presentation.
thorough, very nice. Very good session.
All of you look very consultant neuro-ophthalmologists.
Thank you for the presentations. I think our session is over now.
Can you take a photograph?
So,